Hey guys, it's Sarah. So in this video I'm going to be talking about EKG rhythms made easy. It's going to go over CPR, AED, cardioversion, defibrillation, pacemakers, and the EKG rhythms. CPR, Cardiopulmonary Resuscitation. So what's the purpose of CPR? So the purpose is to establish effective circulation and respirations and to prevent irreversible brain damage from a lack of oxygen. When would you use CPR? You would use CPR if you cannot feel a palpable carotid pulse, and in the picture over here you see where the carotid pulse is, it's by the neck, or absent breath sounds. Here are the CPR steps. First, you assess the scene safety. You want to see that there's no wire, that you're not going to get hurt also, etc. Then you want to see if they're unresponsive. So you're going to tap them. Are you alright? Are you okay? If they're not responsive, then you call 911 and you send someone to get the AED. You do not want to leave the patient. Someone else is supposed to get the AED. Then you're going to assess the breathing and carotid pulse at the same exact time for less than 10 seconds. You have to definitely feel it. If you feel a weak, thready pulse, you still do CPR. So, if the patient has a pulse and is breathing normally, then you just monitor them. If the patient has a pulse and they're breathing abnormally, then you're going to be giving them rescue breaths. So you give one breath every 6 seconds, and you want to check the pulse every 2 minutes and call EMS. If the patient has no pulse or a gasping pulse, then you can do CPR. CPR, you're going to be doing 30 compressions and then 2 breaths, 30 compressions, 2 breaths, etc. until an AED or a defibrillator comes. When those come, then you're going to give a shock and continue CPR. So the compression rate is going to be 100 to 120. The compression depth, like how deep you want to push it in, is 2 to 2.5 inches. And every time you do a compression, you want to allow the chest to recoil between each compression. So basically, if you see a patient with no pulse, you do CPR, which is compressions, and then 2 breaths. CPR, so 30 compressions, 2 breaths. If you have a patient who has a pulse, not breathing, then rescue breaths. When do you stop CPR? So you stop CPR in 3 instances. When a provider pronounces the patient's dead, or when help arrives, or when the patient's heartbeat returns. AED, an automated external defibrillator. What this does is that you place the pads on the patient's chest and it analyzes the cardiac rhythm. You're going to keep doing compressions while it's being set up, and you're going to stop it when it's analyzing the patient, and a mechanical voice will tell you to deliver the shock. Airway obstruction. If someone's airway is obstructed. So if the patient is conscious, you're going to do the Heimlich maneuver until it's successful or until the patient becomes unconscious. To do the Heimlich maneuver, as you see in the picture, you're going to lean the patient forward slightly and stand behind him. You're going to make a fist with a hand, and you're going to put your arm around the person and grasp your fist with the other hand just below the rib cage. And you're going to make a quick, hard movement inward and up, so in and up with your fist and hand. And if the patient is unconscious, like we said before, unconscious, always CPR, compressions. These are stuff that could be done if medications do not work. For a tachydysrhythmia, if it's too fast, you could do the following. You could do cardioversion or defibrillation. So cardioversion, it gives an electric current to the heart to convert it back to normal sinus. It is synced with the patient's cardiac cycle. Defibrillation is the same thing. It's also giving an electrical current to the heart to slow it down. but it is only used for life-threatening dysrhythmias like VFib or pulseless VTAC, and it is not synchronized for the patient's cardiac cycle. Just to recap, for tachydysrhythmias, for dysrhythmias that go too fast, you could do cardioversion or defibrillation. The only difference is that defibrillation is only used for life-threatening, and it is not synchronized, and cardioversion is synchronized. If the patient has a bradycardia, dysrhythmia that's too slow, you could do a pacemaker. So what the pacemaker does is that it gives repetitive electrical stimuli to the heart to control the heart rate. There are two different types, permanent and temporary. Permanent is placed surgically in the chest in subcu. You want to tell the patient to avoid raising their arms until it heals, to avoid large magnets like an MRI. They should carry a health ID, especially to the airport, and they should know battery failure signs. They should wear loose-fitting clothing and do not play contact sports. So here's a quick introduction to the EKG rhythms. So as we see, we have a P wave, QRS, and a T wave. You have to know what each one is. So the P wave is when the atria contracts, the QRS is when the ventricles contract, and the T wave is when the ventricles relax. Basically, you have atrias contract, atrias relax, ventricles contract, ventricles relax. The reason why you don't see the atria relaxes on this thing is because it happens much quicker and it kind of gets lost in the QRS. So all you have to know is the P wave is the atria, the QRS, and the T is the ventricle. QRS is when the ventricles contract, T raises the ventricles relax. So why this is important is because if you have the P wave is not there, you know it's an atria problem. If the QRS or T wave has something wrong with that, it's a ventricle problem. Sometimes you see a U wave, which is like a little wave after the T. Not every patient has it. They think it's because of the Purkinje relaxes, etc., and you don't have to know that. So this is just a quick visual aid to help you if you want to see what the PR interval is, the QT interval, PR segment, QRS complex, ST segment, etc. So you can press pause over here or take a picture if you ever want to go back. Here are steps to interpret the EKG. So there are 5 steps: rate, P wave, PQRS, QRS, and PR interval. So the first one is the rate. So that's how fast the electrical current is going. The way to know the rate is to count the R waves and multiply it by 10. An easy hint to remember this is RR, rate and R waves. As we see in this picture, the R wave is the peak. You count how many peaks you have in a 6-second trip and multiply it by 10. Next one goes the P wave. For the P wave, you're trying to see, is it there? Is the P wave there, or is there no P wave? And you want to see the rate, and if it's upright, or is it slanty, or is it in different shape, etc. So how I like to remember this, I like to say P, P, P. P wave is it present and perfect. So is it present, is it there, and is it perfect? Is it the shape it's supposed to be, or is it slanted and looks like AFib or A Flutter, etc. The third step is PQRS, because there's a colon in between. Just think of 1-to-1 with a colon in between. You wanted to see that there's a 1-to-1 relationship. So for every P is a QRS, etc. Number 4 is QRS. You want to see if it's present, obviously, and you want to see the width. And the width should be 0.06 to 0.12 seconds, which is 1.5 to 3 boxes. So the way I like to remember this is QRS is a lot of letters, so width, you remember the width, and then you just remember a 6-second strip. So we start off with 0.06, and then you double that, so 0.12 seconds. Number 5 is the PR interval. The PR interval, if you finish with the QRS, so you know that ended with 0.12, so you start with 0.12. And so you just want it to be between 0.12 to 0.20 seconds, which is 3, because we finished off with 3 small boxes to 5 small boxes. So basically, I'll just simplify this really quickly. So 1, you're checking the rate, RR. You want to count the R waves and multiply by 10. 2, you check the P wave, PPP. P waves present and perfect. Are they there, and is the shape good? P:QRS, 1:1. is there a one-to-one relationship? For every P, is there a QRS? 4, QRS. QRS, you want to check the width. You want QRS is a few letters combined, so you think of width. 0.6, because you have a 6-second strip, to 0.12 seconds. PR interval, you continue from the 0.12 seconds to the 0.20 seconds. And that's that. Just one last point for this is that you have to remember in all the EKGs, P wave, like we said before, P wave, atrial contracts, QRS, ventricles contract. Why this is so important? Because let's say you go to step number 2, P wave. If it's not present, then what are we talking about? An atrial problem. So your answer is not going to be a VTEC. It's going to be something atrial fibrillation, atrial flutter. It's not going to be a ventricular problem. And the same thing goes with opposite. If the problem is with a QRS, you're going to have a ventricular problem. It's not going to be AFib or A flutter. Before we start talking about different dysrhythmias, we have to know our baseline. So a normal sinus rhythm. So we're going to go through the 5 questions. Rate. So look at the R waves. 1, 2, 3, 4, 5, 6, 7. So there's 7 of them. 7 times 10 is 70. A normal sinus rate is between 60 and 100. So this is a normal sinus rate. Now we look at the P waves. P waves, present, perfect. So P waves, are they present? Yeah. Are they perfect? Yeah. They're round, they're smooth, and they bump upwards. Now we go on to P colon QRS. One-to-one relationship. Yes, for every P, there's a QRS. Now we go on to QRS. Is it there? Yeah, we said that before. And the width, so because it's wide. You want to count, is it 0.06 to 0.12 seconds? Yes, you count the small boxes. There should be 1.5 to 3 small boxes. It's a little hard to see from this picture, but this is. PR interval. You want it between 1.2 to 0.2 seconds, 3 to 5 small boxes. So this is a normal sinus rhythm. You should know a normal sinus rhythm to see your baseline. You always need to know a baseline, and then you can know what's abnormal and normal. Sinus bradycardia. This is when you have a normal EKG. The only thing that's different is the rate. The rate is going to be bradycardia, very slow. So a normal rate is between 60 and 100. And in sinus bradycardia, it's less than 60. And everything else, the 2, 3, 4, 5, are all normal except for 1, the rate. And as we know, rate R, so look at the R waves. You only see 3 in the 6-second strip. So 3 times 10 is 30, that's less than 60. So this is a sinus bradycardia. Causes. Causes are things that slow everything down, like low metabolic needs, like so an athlete or someone who with hypothyroidism, vagal stimulation, someone is bearing down, like going to the bathroom, pushing down, holding their breath like that. Medications that could slow down the heart, like beta blockers, etc. Treatment. In general, you just treat the cause. So if you're bearing down, you stop doing that. If it's a medication problem, you'll switch that up. If the patient is unstable, then you give atropine. Sinus bradycardia. So this is the opposite of sinus tachycardia. So by the name, we see that it's just a fast heartbeat. 2, 3, 4, 5 are all normal, and the only thing that's abnormal is the rate. The rate's going to be faster than a normal rate. A normal rate's 60 to 100, the rate's going to be more than 100. And as we could see, there are much more than 10 R's. You don't even have counting that to see that. Causes. So causes are going to be things that speed up, like an abnormal vital sounds, if someone has a fever, hypertension, pain, etc. Stress could do it, or stimulants like caffeine, cocaine, etc. And exercise. Things that speed up the heart. Treatment. So again, you're going to treat the cause. Fever, you want to lower that. Hypertension, you're going to give medications, etc. If the patient's unstable, they could do a cardioversion. Supraventricular tachycardia, SVT. So these are a series of rapid heartbeats that originate from the atria. So in a normal heartbeat, you have the atria contracts, the ventricles contract. The atria contracts, the ventricles contract. A 1-to-1 ratio. In supraventricular tachycardia, you have the atrias contracting much faster than the ventricles. It's not a 1-to-1 ratio. There are different types. Paroxysmal Supraventricular Tachycardia is a supraventricular tachycardia, so the atria is contracting way faster than the ventricles, but it's paroxysmal. It just means that it occurs intermittently and lasts for however long. So it could occur randomly and last for very short, occur a different random time, and last for very long. The next type is atrial flutter. In atrial flutter, the atria is contracting much faster than the ventricles. So instead of a 1-to-1 ratio like it should be, the atria has like a 3-to-1 ratio, it could be a 2-to-1 ratio, it could be 4-to-1 ratio, etc. In afibrillation, there is complete electrical chaos. So the atria is contracting many, many, many times more than the ventricles. And the ventricles cannot catch up, which puts the patient at high risk for blood clots. The main thing about atrial fibrillation is that the patient is at risk for blood clots, because atria keeps contracting so fast that it's complete electrical chaos, so it's like quivering and it's not getting blood out, so it just clots in there. Now, if you look at the EKG, so normally we have 1, 2, 3, 4, 5. Over here, we're just going to look at 1, 2, because that's it you have to know for all these supraventricular tachycardias. So, AFib and A flutter. The rate is irregular by both of them. So you don't even have to count it. You just see it's irregular. The P wave. So as we know, the atria contracts has to do with the P wave. So there's going to be no discernible P waves with AFib or A flutter. The way you could tell the difference between both of them is that by atrial fibrillation, the P waves there's scribbles, and by atrial flutter, there's waves. So if you look at those two EKGs down there, atrial fibrillation has irregular to R wave, as you could see, and the P wave is like scribbles. The atrial flutter, also irregular R to R wave, which is the rate, but the P wave is waves. A hint to remember this is that just think of fib, someone who's lying, like trying to erase what they scribbled. And flutter, when you think of flutter, think of like a dolphin and like they're waves, they're making waves, not scribbles. So here are ventricular arrhythmias. Before we talked about atrial arrhythmias, now it's ventricular arrhythmias. If the ventricles are taking over, like the heart's at its last stop, so they're called lethal arrhythmias. They're much more serious. Ventricular tachycardia. So this is usually caused by structural heart problems like cardiac scarring, etc. In ventricular tachycardia, the P waves are absent and the QRS waves are wide and bizarre. This is probably the easiest arrhythmia. You probably don't even have to go through the 5 steps. I would just look at it and you just see it's a VTach. If you look at it down below, it's just the QRS is the only thing you could see, and it's just wide and bizarre. There's nothing else that's going to look like that. So that's easy to tell. Ventricular tachycardia in more than 30 seconds is really dangerous because it could lead to ventricular fibrillation. Ventricular fibrillation is the most lethal of them all. Ventricular fibrillation is the same thing as the atrial fibrillation. It's the same thing as the AFib, it's just in the ventricles. Instead of the atria, it's in the ventricles. It's when the ventricles get chaotic, unsynchronized signals, so they just keep beating, or more like quivering, and the heart is not pumping blood out. The heart's not pumping any blood out from the ventricles, so it's lethal. What you're going to see for ventricular fibrillation is irregular waveformings with no amplitudes. So basically, there's no identifiable P waves, QRS, or T waves, as you could see in the picture below. These are very lethal, but they're easy to tell on EKG. Treatment. With VTach, the patient could have a pulse. If they do have a pulse, you give them cardioversion, and you also could give them anti-dysrhythmias IV medications, like amiodarone, etc. If they do not have a pulse, then immediate defibrillation. In VFib, the patient never has a pulse, so you just do CPR and defibrillation right away. AV block. So an AV block is when the conduction between the atria and the ventricle is impaired. So with all AV blocks, the only thing that we're looking at really is the PR interval, as we showed in the slide before. In a regular PR interval, you want it to be less than 5 little boxes, and you want it to be in between 0.12 to 0.20 seconds. So with AV blocks, you're going to have a prolonged PR interval. So you're going to have the PR interval more than 5 small boxes or more than 0.20 seconds. There are different types. First I'm going to tell you about them, and in the next slide we're going to show you about them with the little poem. So first degree. First degree is when it's just prolonged. The PR interval is prolonged and constant. There's nothing dropped, there's no QRS drops, just prolonged PR interval on a constant, steady basis. Second degree. There are 2 types. Mobitz 1, Wenckebach, Mobitz 2. Mobitz 1, which is also called Wenckebach, is that the PR interval gets progressively longer. So in first degree, it was constant PR interval prolongation. Over here, it gets longer. So it starts at a little long, gets a little longer, gets a little longer, until a beat, which is a QRS, is dropped. So you're going to have longer, 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 a drop of a beat. Mobitz 2 is when the PR interval is lengthened and a beat is dropped. So it doesn't get progressively longer. It's not like longer, longer, more longer than that, more longer than that. It's always lengthened and then a beat's drop. The way to remember the opposite of Mobitz 1, Mobitz 2 is that Mobitz 1 is called Wenckebach, so W, it gives you a warning. It gets progressively longer and then it drops a beat. As opposed to Mobitz 2, it just is lengthened, then drops a beat. Then it goes third degree. Third degree is the most severe. Third degree is when the atria and the ventricles are contracting independently of each other. As we know, the P wave is the atria contracting, QRS is the ventricles contracting. So the atria is contracting normally, the ventricles are contracting normally, just completely independent of each other. So you're going to have constant interval for P to P interval, and you're going to have constant Q to Q interval, but they're going to be random and independent of each other. Here's the heart block poem, the famous heart block poem, which helps you remember the degrees and you can know how to identify an EKG. So if the R is far from the P, then you have a first degree. Longer, longer, longer drop, then you have a Wenckebach, which is the second degree. If some P's don't get through, then you have Mobitz 2. If P's and Q's don't agree, then you have a third degree. So that's it for the EKG rhythm. I hope it helps you. Please check out my other videos. And remember that the rhythms that they give you on the test, in real life, it's going to be harder to tell. It's not going to be so exact. And just practice makes perfect. Good luck. Please subscribe and like. Thank you.